Good afternoon, everyone, and welcome to the ASTCT Town Hall webinar on COVID-19. This is the second installment of our Town Hall webinar series on this topic. The previous webinar was held last week on Tuesday, and those slides and recordings are up on our website for your reference. My name is Kira Newman, and I'm the Senior Coordinator for Education with ASTCT. We want to thank you for taking the time out today to join us and discuss the current pressing events. I would also like to thank our speakers on today's webinar, ASTCT Past President, Dr. Navneet Majhail, and ASTCT Transplant Infectious Disease Special Interest Group Leadership, Dr. Zenia Papanicolaou and Dr. Michael Boeckh, both who helped author the ASTCT guidelines for COVID-19 that will be discussed today. The slides and recording of today's webinar will be distributed and posted to the ASTCT COVID-19 community page after the webinar today. There will be a section for question and answer at the end of the webinar. If you have any questions throughout the presentation, please submit them using the GoToWebinar control panel on the right side of your screen, as seen here. If we are unable to answer your question during the webinar, you may email us at info@astct.org or post them to the COVID-19 community page. We'll be sharing a link on how to access that page during the presentation. At this time, I would like to hand the webinar over to ASTCT Past President, Dr. Navneet Majhail, who will discuss the agenda for today as well as the current landscape in the United States. Dr. Majhail?
Thank you, Kira, and good afternoon, everyone. Thanks for taking the time to join us today. These are unprecedented times, and as the COVID-19 situation evolves, there are a number of issues and concerns about how we manage our BMT and cellular therapy patients that we need to address. Our society, the ASTCT, continues to work proactively to put out information and educational materials out there. And we will keep working on this as we go along, and we learn more about this virus and how it impacts our patients. And as we start, I want to give a special shout out to our Transplant Infectious Disease Special Interest Group members who have been working so diligently and so proactively to take charge and provide guidance to all of us during these pressing times. So what we'll do today is we'll briefly review the current landscape of where the coronavirus SARS-CoV-2, COVID-19 is in the context of BMT. We'll provide some very high-level overview of the guidelines and the process that we have for updates. And as Kira mentioned, we had a very robust and successful webinar last week, which goes into the guidelines in detail. And I'll encourage you to take a look at that if you want more information on what we are suggesting. I do want to mention here that our Transplant ID group is working very hard to keep those guidelines up to date as the information changes so rapidly. They're meeting by email and by phone several times a week just to make sure the guidelines represent the most up-to-date information that is out there as it relates to our patients. So towards the end, we will talk about some ideas and guidance on what we can do at the center level to address some of the practical issues as we think about addressing this infection. And then we'll open it up for some Q&A. And we've also had questions come in as you registered. And we had some questions from last week's webinar that we could not address in a timely fashion. So at the end of the day, we hope we'll leave you with some ideas as you think about your own centers and your own patients who are coming in for BMT and cellular therapy. Kira, can we go to the next slide, please? So this slide basically provides some guidance on how to access last week's webinar. So last week, we had Dr. Alpana Wagner and Dr. Roy Chumali from the Transplant Infectious Disease SIG work with Dr. Pawan Reddy, our current ASTCT president, and they all collectively did a great job of summarizing our guidance on what to do for BMT and cellular therapy patients. And these slides and this webinar will be posted on our website as well. And as you can see, you can click that link and go to our ASTCT community webpage for COVID-19, and you can access the details of the guidance and the webinar from there. Next slide, please. So this slide summarizes the current landscape of what is happening in the US as of yet. And I mean, things keep changing rapidly every day. And based on what we have since yesterday, so even I think since this slide was put up, the demographics have changed. And at least as of yesterday on Sunday afternoon, from the CDC website, there were close to 123,000 cases of COVID-19 in the US, and more than 2,000 deaths have been reported. And obviously, the data and information is evolving pretty rapidly, and we're all trying to keep up with what's happening in the US as well as worldwide. Kira, next slide, please. So as I mentioned before, our Transplant Infectious Disease SIG colleagues have developed guidelines for COVID-19 management for transplantation and cellular therapy recipients. And again, as I mentioned before, we have a great process of trying to make sure we're keeping this information as up to date as possible. And I should mention here that we're also collaborating with our colleagues from Europe just to make sure that we're learning from each other and also coordinating our guidance as we go forward. Next slide. So I'll just want to share some practical guidance for transplant centers. In the Q&A section, we'll talk more about this. We'll refer to some of the guidance that is out there, and we can learn from each other as we think about what each center is doing. I do want to call out Drs. Dahi, Dr. Barker, and Dr. Pirales from the MSKCC Adult BMT Service, who took out the time to put that on paper, what they are doing at the MSKCC. Again, if you look at those guidelines, that guidance, the link is available on this slide and will be available to you after the webinar as well. And if you click on this link and look at that guidance, there are some ideas I think all of us can apply to our centers. I suspect most of us are doing many of those things anyways, but I think this is a good opportunity to learn from each other and see and assess how we're all individually at our centers trying to address this. And hopefully we can collectively come up with some ideas that can help us take care of patients better. And if you look at this guidance, what they've done is they've tried to address several questions that we were getting about the operational aspects of what centers can do with respect to, disaster planning, how do you protect patients and clinicians, decision-making process for delaying transplants and cell therapy infusions, how do you address the inpatient and outpatient workflow and staffing and so forth. So again, I'll encourage you to take a look at this document to get some ideas on what you can potentially apply at your own center, looking at what the local prevalence of COVID-19 infection is in your area, and obviously how you can align some of that to what your institutional policies are. Next slide. Before we open this webinar up for questions and answers, I also want to talk about what the CIBMTR is doing to facilitate data collection for COVID-19. So obviously, we all recognize that there's a need to systematically learn more and learn more very quickly as to what is going on with our BMT and cell therapy patients. The CIBMTR has come up with a data capture mechanism, and they are working on strategies to rapidly share the information they collect as well in a more real-time manner as we go forward. So this slide summarizes some of the mechanisms that the CIBMTR has set up. If you are a CIBMTR center, you probably have already received an email that provides more detail. But very briefly, as you all know, CIBMTR collects data on two tracks: the comprehensive report form, or the cellular therapy track, and the transplant essential data, or the TED track. And if you are a CRF or a CT track center, there are opportunities to report data on post-transplant follow-up on those forms listed there, and which have been updated with a new organism option for COVID-19 or SARS-CoV-2. If you're on the TED track, I understand you'll be receiving more information this week on how to provide information on your patients who get diagnosed with COVID-19, either through ServiceNow or another secure CIBMTR website. The CIBMTR is working on a new on-demand form called 2149 that will be available to register COVID patients starting April 24th, 2020. So again, look out for more information on these forms as we go forward. And I do want to mention here that these forms will capture data on the diagnosis, treatment, and outcome of COVID-19 infections, and centers will be reimbursed for providing data on both the CRF, CT, and the TETRAC. So again, more information will be coming from the CIBMTR. We have a link here for the CIBMTR website. They are working on a new landing page with more information. And as we obtain that, this link will be updated as well. Next slide. So at this point, we are going to open up the chat for questions. So as you listen to our conversation, you have questions that have not been addressed, please write that or type that in the chat function of this webinar. In the meantime, just to get things started, what we'll do is we'll look at some of the questions that were left over from last week and the questions that we have received during the registration process of this webinar. And maybe what I'll do is first I'll start with some questions that we've been receiving about testing patients and testing donors prior to cell therapy or their transplantation. So maybe I'll go to Dr. Boeckh first and then to Dr. Papanicolaou, and I'll ask you to help us out with what the guidance and recommendation is. How do we test, and what are the suggestions on looking at patients who are asymptomatic prior to their cell therapy? So Michael, I'll maybe start with you first.
Yeah, so I'd like to welcome everyone, and thanks for joining us. Yeah, so I'll start with the patients. Similar to the principles that we have for other respiratory viruses, we'd like them to be asymptomatic. And when they go into transplant, if we decided to move forward with the transplant, so since the pre-transplant workup process typically extends over a period of several weeks, this may require not only one-time testing, but when they enter the system, and then also directly before they move forward with the transplant conditioning. So that is what is currently recommended, and they should be negative at those time periods and asymptomatic as well.
Okay. Zenia, what are you doing at your center at MSKCC?
Hi, thank you and welcome everybody. We do the same, we follow the same principles. Patients should be asymptomatic, and we have a testing within 72 hours of admission for conditioning, and we require this test to be negative. Sometimes we hear about people, transplant candidates that have been exposed to COVID, and for those, if feasible, we require 14 days of waiting deferral, and then be asymptomatic and have a negative test for COVID.
Yeah. And one of the questions we've been receiving from our colleagues is how many tests are necessary, 1 versus 2? And I think some of the impetus for this question is obviously the limited availability of this test in some areas. So any thoughts or suggestions on that? Michael, I'll ask you to go first. Yeah.
Maybe I'll start. There's no clear answer to this. Obviously, to give you more certainty, but that's not always feasible, depending on the testing capability, as you pointed out. I think at the moment we require a minimum of 1, and that the person is asymptomatic.
Okay. Now, if an asymptomatic patient comes back as positive for COVID-19, what guidance do you have for their caregivers? I mean, do they get tested as well? How should we proceed in that context? Zenia, I'll have you go first.
Yes, this is a difficult question because per se, our center, the caregivers are not our patients. So this has come up now, but as of now, we are not testing relatives or caregivers. And I think it is a very relevant question. So we have not been doing that. I would assume that we suggest to the caregivers to be tested on their own from their primary care provider. And now that there are more tests available, that is feasible. In the beginning, as tests were limited, this option was not even available. I think that we will be seeing more and more caregivers being tested, either for patients being positive or for patients returning home where the health caregiver may be exposed or positive for COVID.
Right. Michael, what are you doing in Seattle?
Yeah, very similar here. There is no default testing of the entire caregiver team or family. In the past, that was partially due to test availability. This is now rapidly changing, and that we also recommend that they are being worked up separately. One big question is obviously then what to do with the result, because they depend on their caregivers, and these are questions that are really debated right now, and there is not a good universal answer. It may depend on the circumstances, but yeah, that's where we are right now.
Okay, so I'm going to switch from recipients to donors. Zenia, what is our guidance from your perspective for donor screening?
So the related donors that we screen, they have to be asymptomatic, and they have to have a negative test for coronavirus 19 within 48 hours prior to starting any procedures. And they are also advised to limit exposure, although now this becomes difficult with so much widespread community transmission. However, since everybody is really on house quarantine, that applies also to donors.
Mm-hmm.
So basically a negative test within 48 hours prior to starting, and common sense to avoid exposures.
So at your center, you're testing donors, related donors prior to donation, Zenia?
Yes.
Okay. Michael, what is your approach to this?
Yeah, similar here. There, to my knowledge, there hasn't been really any transmission through the stem cell or bone marrow product yet, and it's actually been also for the other respiratory viruses thought to be rare, or at least I'm not aware that it ever happened. But this one is potentially different because the data from China indicate that at least RNA can be found in the blood during the course of this infection, so far mainly during the more severe stages. But there is concern and uncertainty how far the spread is. So generally an extremely cautious approach, as outlined by Dr. Papanicolaou, is recommended at this point, and to be really be able to provide a safe product.
Yeah. And again, I think just as a reference to the listeners, NMDP has its guidance for unrelated donors as well. And I think at this point, they are minimizing donor contact with the donor centers. So they've changed some of their processes to minimize how often donors have to come in to be counseled and tested. And more so, they are not, I believe, actively testing unrelated donors for COVID-19 or SARS-CoV-2, but they are screening them carefully. And they have some guidance on their website, which I'll encourage you all to take a look at. Okay. Now, a lot of interest on the treatment options for COVID-19. And I'd like you both to teach us about some of the hot topics out there, like remdesivir, the convalescent plasma. Hydroxychloroquine has been so much in the news right now, and obviously tocilizumab. Maybe we can start with hydroxychloroquine, because as you know, the FDA just put out an emergency use authorization for this drug yesterday over the weekend. And I'm sure a lot of us and a lot of our colleagues have questions about who to use this on. I mean, what is the guidance on prophylaxis, if any, and who might be candidates for this? So maybe, Michael, I'll ask you to go first, and then Zena will come to you.
Yeah, and I think Zenia will definitely have more to add because New York is heavily affected and a bit more than we are. But I think what the emergency use utilization actually says is that if you are able to enroll somebody in a randomized trial, you should. And I definitely want to echo that, and that's what we are trying to do. We have our CTs ongoing that we will try to put people on, because data is for any of these substances not of high quality at the time, so we desperately need to have some real knowledge generated. If that doesn't exist, I think chloroquine is there is I think concern about the potentially cardiac toxicity, acute prolongation, because we often also give additional drugs, or have to give additional drugs that can also QT prolongation, such as some of the azoles or some of the quinolones, as well as others. So as we now give more of those at the same time, I think we really have to be concerned that we are staying or keeping our safe. EKG monitoring is not always easy, and is to some degree at some centers also discouraged or regulated, because it requires people to go into the room more often. So it's not an easy questions. I think at the moment we have not come down with a blanket recommendation to give it in all cases, but it is available at this point. And I give it now to Zenia. She can give you her perspective.
Yeah, it's similar in our center. Obviously, everybody wants to do something for these patients, but the data for hydroxychloroquine or even for chloroquine that is coming from China is still not extremely convincing. These patients in China were treated with multiple modalities, including hydroxychloroquine. They were getting other antivirals, other immunomodulators. So it is not entirely clear. We'll have to see if any results are coming from randomized trials. However, since this was the only thing we had, in our standard of care, we consider giving it in patients that are only hospitalized, so they have symptomatic COVID, not those that have mild illness, but those that have some kind of symptom, whether this is fever, maybe oxygen requirement, even though not a lot. So we can give it for somebody that requires hospitalization. Again, we are running into issues with QTc, as Michael said. We have to test for G6PD, and we are always conscious with concomitant medications, not only including anti-infectives such as azoles or quinolones, but also some of the leukemia drugs that are given in relapse patients that we see. And obviously now with the new executive order that patients have to be, chloroquine has to be given under clinical trials, we are funneling the patients to a randomized clinical trial.
Okay. No, thank you for that insight, Michael and Zenia. So switching gears to convalescent plasma. So obviously a lot of interest in that, and maybe Zenia, I'll pick on you for this. I mean, just a reminder to our colleagues about why are we even thinking about this, and where things are at present with its availability and the data on its efficacy in this context.
Yes, so convalescent plasma or hyperimmune immune globulins have been used for various indications in the past with not really conclusive results. And this convalescent plasma for COVID has also been used in China with some small series that are uncontrolled. However, they show some positive results in even in sick patients, including clinical improvement and radiographic appearance. Again, these are very small series and uncontrolled. There is several centers are trying to do this by themselves. There is a bigger movement organized by Hopkins and the Mayo Clinic. It's called CCP19. They have a website and they are mobilizing resources. Eventually, what has happened now is that the FDA has issued an emergency IND that they will allow the use of convalescent serum in certain patients with severe disease. So these patients have to have had dyspnea, respiratory rate more than 30, blood oxygenation saturation less than 93, blood lung infiltrates, etc. This is all outlined in the FDA website. And with regards to the plasma collection, all the standard criteria for plasma donation apply, plus a prior diagnosis of COVID-19, a complete resolution of symptoms at least 14 days prior to donation, and a negative results of COVID-19 test from either nasopharyngeal swab or a molecular diagnostic test from the blood. Now, we are in a situation that there are certain pitfalls. Ideally, we would like to know the neutralizing antibody titers of this plasma. Right now, to my knowledge, there are not neutralizing antibody assays available. They are being developed. There are not even ELISA antibodies assays available right now. They are also being developed. And that is why actually testing for antibodies is not required by the FDA to provide this convalescent serum. The FDA does not provide the serum, the plasma themselves. The centers need to identify donors, screen the donors, and have them collected in one of the blood collection centers locally. So there are a lot of unknowns before this will proceed into randomized clinical trials. There are some clinical trials that protocols are coming forward. One is for prophylaxis of healthcare providers or exposed household members. The other is for patients with severe disease, and the third one is what they call a Hail Mary protocol in patients that have organ failure, etc. However, none of these protocols can move forward before the FDA weighs in them. So this is where we are right now.
Yeah, and I think, thank you, Zenia. And just to add on to that, and obviously in the BMT cell therapy space, many of us in our centers have apheresis units as well. And at least at our institution and many others, there are questions being asked around what can the apheresis centers do to collect plasma for this indication. And I think just to give a reminder that the FDA guidance is pretty specific, at least for the emergency IND, that the collection has to happen in a blood center, right? So most of our, or many of our apheresis collection facilities are not designated blood centers. And those are some things you have to think about as well as you consider what options you have for collecting this plasma, which, as you said, Zenia, is ideally done in the context of a clinical trial, right? Now, thoughts on tocilizumab? Michael, your thoughts about what role tocilizumab has in this context?
Yeah, so there's, I think it's at the moment also one of those questions that are unfortunately not really well understood. The answers. So it's being used in the ICU setting. There's some data coming out of China, and randomized trials are being organized and conducted. So again, our recommendation is to participate in those if they are available, and otherwise to give it in selected settings. Potentially driven by actually IL-6 measurements, and see if cytokines are high. We're still at the stage of an individualized approach, since there's no definitive knowledge yet that is out there. But this is a rapidly changing field also, and I think there's a lot of variation in how this is being handled from side to side. That's what I can say at this point.
Okay, and I'll ask Zenia you to address this first, and then Michael. And for our listeners on the call, on this webinar, I think one of the pressing questions is, how do you align, or how do you think of all these treatments that we've talked about, right? So there's not enough data. There is very scant data on how well that works to begin with in COVID-19, and obviously essentially no data in the context of our BMT and cell therapy patients. But as these patients get very sick, they have ARDS, and obviously we're all trying to do what we can to salvage them or save them. What is your approach at your centers as to how do you use these different therapies, or how do you put this all together? Maybe Zenia, I'll ask you first, and then Michael, your thoughts for our listeners.
Yeah, that's a very tough question, as we have limited information, incomplete information, and also limited availability of what trials we can participate in. What would be my personal, so right now, other than the randomized trial of hydroxychloroquine versus placebo that we are just setting up now, previously we were giving it as standard of care, we do not have any other randomized trial. We had not been able to participate in the Remdesivir trial, and Michael may be able to provide more information on that. What I would like to do is that the trials are basically in three big buckets. One is antiviral, so primarily focused in killing the virus. In this type of situation, I would favor trials that intervene early, before the patients are in the unit, before they have established ARDS. I do not know if a very viable candidate antiviral has come forward. I really hope it does, because that would be a way to intervene early from what we know from other respiratory infections that may be the best before the downstream cascade of inflammation and other badness sets in. Now, the immunomodulators are kind of interesting. IL-6 blockade, transplanters are very familiar with it. However, it's not given in a setting of an active infection. So I am a little bit skeptical of giving the IL-6 blockade in a setting of an active infection. There is now a trial in China with the antiviral favipiravir with tocilizumab, or the antiviral alone, or toci alone, and that would be an interesting trial. We don't have the equivalent of that in the US, but certainly I think that right now we give IL-6 blockade on a case-by-case basis, and not in a very controlled manner, because we don't really have a good surrogate market where the IL-6 blockade will work in these patients.
Yeah. Michael, your approach to a patient who is sick?
So we actually we have a Remdesivir trial ongoing here, and we are really actively putting people on it. That's going really well. And then same principles. I mean, these are probably, if these substances have an antiviral effect, there probably is somewhat moderate, and using them early is a higher likelihood of success. I've always been kind of in favor of, if you do this in the absence of data, at least whatever you do systematically in a certain way, so that you can at least get experience, and not just doing it completely kind of individualized, because then it'll be very hard. Even, I mean, sooner you will have 20, 30 patients. At least you can in some way look at this and try to make sense of it. And one of the crux of these earlier data, and also what we haven't talked about it, but actually many people are talking about it, is the stuff of the combination of erythromycin There is this at face value, if you just look at the headlines, looks I think very interesting, but if you really dig into the paper, how this was done, there's a lot of problems with this type of analysis. And so if you do something, do it consistently so that one can eventually make a conclusion of at least in the context of the non-randomized trial, whether something works or not, or whether toxicities or problems occur. That's what I can say, and I think this is how several sites, and including ours, people come up with some internal guidelines, and I think that's a good thing rather than doing it completely free for all, that everybody does it differently, because then by June we will know nothing, right? So I just want to, and that feeds into also this CIBMTR case report form that was mentioned earlier. So whatever we do, we encourage you to document it, that if we have a large enough case number, we can at least try to analyze things in a bigger data set with a multivariate analysis, et cetera, that we by the summer potentially have some kind of knowledge that we gained in addition to the RCTs that are being conducted and started.
Yeah. So again, I think that's great advice. And I should give the disclaimer that everything we're talking about is, from a treatment perspective at least, is applicable for March 30th, 2020. I mean, things are changing so fast. Hopefully in the next few days we'll have more information and we can adapt. Now, I'm going to switch gears here because a lot of our colleagues have questions about personal protective equipment, PPEs, right, both from a patient perspective and the clinician perspective. So Zenia, I'll maybe start with you because you're in the thick of this right now in New York. I mean, what are you doing to protect patients and your colleagues and yourself from this virus and this infection, given the circumstances we have right now in the U.S., where the availability of some of these resources is very limited?
Yes, thank you, Navneet. A very important question and a moving target. We are doing different things every day. Right now, we are focusing in prevention of nosocomial transmission of COVID. We already have had certain cases that I cannot speak from infection control, but certainly I can speak that in terms of timing, the patients have been in the hospital for weeks and were tested positive for COVID. So as of today, everybody is given a mask and has to wear it all the time at work. And all the patients that are admitted are tested for coronavirus 19 before admission. And so we have to triage them whether they are positive or negative and place them in appropriate floors. Of course, for transplants, we try to, and for every patient who has COVID, we try to minimize the provider. We are cohorting the COVID patients. We have a doctor of service, and that is the only one that goes and sees patients. All others, if we can avoid, unless it is critical for the patient, we are not entering the patient's room to minimize exposures and also preserve PPE. And this is what we do as of now.
Yeah. Michael, your thoughts on what we can do in the context of our resources?
Yeah, this is clearly also here a moving target, lots of discussions. We do not have a universal mask policy for everyone to wear, which other centers are advocating. This is partially driven by simply we don't have them available. Or if we would do that, we would run out in a matter of days. So until the supply stream is being addressed, we, I think, are not able to do it. Otherwise, it's very similar to what's being done in New York. We're trying here to, we've been interested in self-testing for a while here in Seattle, and the FDA has now endorsed it for at least on-site testing, which saves some PPE. If you can give people who can do it hand them their kit that they can test themselves, then that you save that somebody else completely dresses up to administer that test. So that I predict will become available and spreading pretty soon here, and I'm actually very excited about that. And the next frontier will be the home testing, and we are waiting for more guidance here on a daily basis as well. Yeah, so those are some of the newer things that that one can do to save the PPE for those who really need it in the higher stress settings, and hopefully we're going to get more supplies here soon as people start making those.
Yeah, no, I hope the listeners appreciate the fact that this is a complicated discussion. I mean, in an ideal setting, we would have had enough masks to go around, so we would not be asking this question. But given the reality of what we have with PPE shortages, I mean, unfortunately, we have to be more careful and judicious about what we do. And I suspect that partly depends on the prevalence of COVID-19 locally based on the testing that's going on. And obviously, other things your institution is doing, for example, temperature screening, other things in place to triage and identify high-risk patients, right? And then in that context, try and use these PPEs more judiciously. Now, a related thing that we've been asked by many centers, your guidance on what to do with the positive pressure ventilation that we have in our units fairly often. Michael and then Zenia.
Actually, I can't comment on that. I'm not.
Okay. Yes, Zenia, what are your thoughts on that?
Yeah, I would defer on commenting on that as well.
Okay. Yeah, and again, I think I can tell you at our institution, we've had a lot of discussions with infection control on what to do with positive pressure ventilation. And I know some centers probably have shut it down, others have not. And at least our rationale here has been that, well, at least we haven't shut it down as yet, but some of the discussions we've had with infection prevention are related to why we use positive pressure ventilation that has historically been to prevent mold infections. And given that we have good antifungals, at least at this point, that can control fungal infections, and at least for now, we don't have a lot of COVID-19 patients positive in our institution. But if and when that goes up, I think that would be something we'll be coming back to in case we do have to house COVID-19 patients on our BMT units, for instance, as much as we want to avoid that where possible. But I think for the listeners, it'll be good for you all to at least get a sense of, if you do have to turn it off, I mean, who are the people in your institutions who can help you out with that down the road if needed. Now, Zenia, how are you placing and where are you placing your patients who are COVID-19 positive? And how does that relate to where your BMT and cellular therapy patients who don't have COVID-19 relate? I mean, how are you structured at the MSKCC right now?
So one of the floors, actually 2 floors of MSK have been converted to, they are COVID floors. One of those are for patients with hematologic malignancies, including HCT. So they are housed for now either in that floor, or if they are in the unit, we have a few in the unit. Currently, we have 64 patients admitted with COVID overall at MSK and 16 patients admitted in the ICU. Only a minority of those are hematologic malignancies, and even less minority, they are transplants. And as I mentioned, some of the transplants have relapsed disease. And so they are placed on a floor, and they are being cared by a service physician, which is a hematologic oncology physician. And that is the only physician that enters the room unless there is any critical need for somebody else to examine the patient. And of course, the nursing staff are going in the room to provide care. And we have no visitors, or no visitor policy, except in pediatrics. Yeah, I think that's it.
Okay. And Michael, how are things structured at the Hutch?
Yeah, conceptually similar. Our numbers are not that high, so we have reserved certain areas of wards for this. We haven't really sealed off entire wards, but those plans are contingency plans, and we're probably going to move in that direction very soon as the numbers go up. Very similar principles.
Okay. Now, moving on here, I think one of the questions that came up was looking at donors and who do you cryopreserve. And first, looking at the unrelated donors, and again, the NMDP has put out some guidance on that, and I'll refer you to the NMDP website for the specifics of what they're suggesting. But the NMDP has a strong recommendation to cryopreserve all products prior to starting conditioning regimen. And some of the other things that the NMDP has put out there is obviously have a preference for domestic donors over international unrelated donors, given all the uncertainty about the testing piece internationally, the screening piece, and more so the transport of products here on a timely manner, given how things are evolving on a day-by-day basis. The other piece that they've suggested is also to prefer PBSCs over bone marrows if it's appropriate. And the concern there is with how rapidly the situation is evolving, there is a possibility that to conduct a bone marrow harvest, there may not be ORs and anesthesiologists and other providers available. So again, they're suggesting cryopreserving all products and using PBSCs preferentially for unrelated donors. In the related donor setting, I think there is some variation in what centers do. I think some centers are already asking all related donor products to be cryopreserved. At our center here, we are looking at this on a case-by-case basis. If the donor lives far away and has to travel here, then sometimes we are cryopreserving that product because we just don't know how some of the stay-at-home orders and other policies will impact donor travel. And sometimes just a travel piece can expose somebody to coronavirus and COVID-19. I think the other piece is obviously if there's a donor who is more local, then we are not cryopreserving. But obviously all donors are being counseled, related donors are being counseled about precautions they need to take to minimize risk of exposure. I think the other thing I will encourage everyone to think about is the related donor services by the NMDP. Do take a look at that if that applies to you. They have, I believe, cut down the rates and also cut down the contractual requirements just to get things going. So that is also an option for your related donors for collecting their products and doing their workup, what have you, before the transplant of your patients. Now, Zenia and Michael, what are some of the precautions you're suggesting family members and caregivers for COVID-19 patients they should take? And also for our transplantations early on post-transplant, if you will. Michael, maybe I'll go to you first.
Yeah, and I think we just suggesting an enhanced following the general recommendations really to the letters and the meaning, and really taking this very seriously. And so to minimize exposure of the potential recipients, or either the candidate or the actual recipient. And we are thinking of, but we haven't done it yet. If we just get a survey of what the positivity rate of those family members is. That would be interesting to know what kind of the prevalence of subclinical shedding is in those. Nobody has, to my knowledge, really done that. So at the moment, we just keep it with recommendation to minimize contact and also minimize their own exposure and potential. They might then carry back into the families. And okay. But there is not really a laboratory approach yet that we're that we're recommending.
Okay. Now, one of the questions that has come up through the chat is anyone working on development of a viral specific T cell against this virus, and is that even a viable option for this? Zenia?
I have heard that Vir is developing coronavirus 19 specific T cells. That was a recent announcement. I do not know at what stage they are to release them or test them. Some of my concerns would be in a case of a pulmonary inflammatory reaction, whether such cells would create additional inflammation, and we would see an inflammatory response as we see sometimes with the CTLs that we are more familiar with, like CMV-specific CTLs. And so I know that people, so Vir at least is one of the companies that has committed to do that. I think it's an interesting concept, but this would be my hesitations to see how a CTL in a setting of a pulmonary infection that's already inflammatory, how it will behave.
Okay. Now, in the chat, another question that just came up is advice on tuberculosis screening before giving tocilizumab. Michael?
Say that again.
The screening for TB before giving toci.
Yeah,
is there a need for that before we give tocilizumab to patients? Do we need to screen them for tuberculosis?
I'm not aware of a specific one, but I think it's always a good idea. And many of our cancer patients have been kind of assessed for that anyway, earlier at least, when we get them into the system. So yeah, if that's not a recent one, I mean, I'm frankly not aware of that there's any general recommendation, but generally that is a concern. And if there is yeah, evidence that this might be an issue, it's actually perhaps not a bad idea if the time allows, right? And I think those are moving targets. And very good points that need to be addressed. I just want to go back to the T cells also.
Yes.
Because yes, there is of course toxicity with the administration in a context of a pulmonary disease, but it's also at this point we don't even know what the immunologic control of the virus is, what roles T cells versus antibodies play. The assumption is that that antibodies, at least for most respiratory viruses, are perhaps more important, but even that's not 100% sure that we can now make T cells for directed at respiratory viruses. And there have been some association for other respiratory viruses. For this particular one, we actually don't know that yet, how the disease is controlled by T cells, and if at all. So that's a little bit of note of caution. So whatever is done, I think, should be done in a very controlled setting, as in the context of a study, that all those things can be addressed and any adverse events are carefully recorded, so that we're not doing harm inadvertently.
Yeah. And I just saw another question that came up in the chat, which refers to the donor testing piece. And the question is, should donors be tested 48 hours prior to the conditioning of the recipient or 48 hours prior to donation? Michael?
Should donors be tested
48 hours prior to recipient conditioning or 48 hours prior to donation? And I would imagine this is maybe in the context of if you want to cryopreserve the graft, right? So that happens maybe before conditioning. How would we approach that?
I mean, I would say
do it. I can give.
Go ahead. Zenia, go ahead.
So we screen and swab all asymptomatic donors within 72 hours of their line placement and or collection. However, we cryopreserve or recommend to cryopreserve all related and unrelated donor products ahead of transplant admission. So this is what is the testing.
Okay, so I would imagine prior to that donor donating is when you want to test it, right?
I mean, it's prior to donation. That's the important part.
Yeah, because they can potentially get exposed after the donation, but that would not impact the recipient directly, right?
Right.
Now, I think one of the questions that has also come up is how do we make decisions on which transplants to proceed with and which transplants need to be delayed. And I'll encourage our listeners to look at the guidance document that our colleagues from the MSKCC have put together and was referenced to in one of the previous slides. And at least at our center here at the Cleveland Clinic, I mean, these are always tough decisions. And one of the approaches we've taken is one, we're all looking at this collectively as a group so that all physicians can talk about this in a selection meeting and come up with criteria proactively for your center. And the transplants that we are postponing are diseases that can wait. For instance, auto transplant for early myeloma. I mean, if you have an MDS patient who is early in the disease process, has a clear indication for transplant, but is well maintained on azacitidine, for instance, you may be able to delay that transplant, that allo transplant. Low-grade lymphomas, for instance, stable MPNs, myelofibrosis. And obviously, if there is a patient who has a very low likelihood of disease-free survival, such as they have active disease, then maybe you want to think about what's the likelihood of benefit with the transplant in that context as well. Zenia, I mean, obviously you're in the midst of this right now. Any other thoughts or guidance on this from your experience?
No, I think that we learn as we go, and there's no precedent for that. So we are experiencing things that we would never think of experiencing at a major cancer center. It's a sobering situation not to have adequate PPEs, having to practice medicine really in a different way, thinking of whom to send for a CAT scan, what would the CAT scan, how would it change management, and even how to even ration antibiotics, meaning that we need to preserve antibiotics in case of shortages coming in the future. So it is a very new era.
Yeah, no, that is very true, Zenia. Michael, any last concluding comments or thoughts from you?
Yeah, that was a very good summary. Yes, some of us who work in infectious diseases and respiratory viruses have thought about those things in some terms for a long time, but I think nobody could have ever imagined how it would really come to reality, and what terrible situations this sometimes brings us into. And but I think we are all we have a great group of people across the country within our society who are very dedicated to thinking these things through and providing the best possible guidance that we can provide. And we definitely appreciate all your questions, which stimulate our updated guidelines, and we will add comments to those points that we were not able to address during this hour. And I personally like the idea of potentially in the future adding a critical care expert to this one of these webinars, that we can get the questions in this field also answered, because I think that's of key importance to some of us.
Yeah. No, and thank you, Zenia and Michael, for your help today. This has been a very good discussion, and obviously, like you said, unprecedented times. And I want to emphasize to the listeners that the ASTCT will continue to keep working on this. We are collaborating and learning from our colleagues in other countries as well. And please do send us more questions, which we will keep addressing in future webinars and blog posts and so forth. Kira, I'm going to hand this back to you.
Thank you, Dr. Majhail, and thank you to all of our panelists for generously volunteering your time to speak on the webinar today and address some of the direct questions that we've been getting relating to this outbreak. I want to point out just again a few key resources. Our ASTCT COVID-19 community page is up and running. We will be posting the slides from this webinar as well as the recording on that page. But there is also opportunities for discussion posts. So if you have any questions that we weren't able to address here today, I would encourage you to turn to that page. There is also a talent learning network that is currently being conducted by Dr. Christopher Dandoy regarding sharing knowledge and experience on different implementation and treatments at different facilities. And I've also linked here the CDC COVID-19 information for healthcare professionals as well. And this is all in addition to some of the other resources we spoke about earlier on the presentation, like CIBMTR's website, where they're doing some pretty intensive data collection. So please feel free to check those out as well and reach out to us with any additional questions. Thank you all for attending the webinar. And you can reach out to us by email, our website, or social media at any time. Thank you and have a nice day.